Good afternoon to all. At the outset, none of the authors have any financial disclosures pertaining to this study. So the question is, we as refractive surgeons, do we need to understand the collagen or study the collagen? We do have various topography, biomechanics, and OCT-based indices which helps us to diagnose normal from suspect keratoconic eyes, and which tells us whether to do a refractive surgery or not do a refractive surgery, and also helps us prevent ectasias. But however, there are limitations where we do come across cases where topographies and biomechanics are normal. Sometimes topographies are normal but biomechanics is suspicious, and sometimes when topographies are suspicious but biomechanics are normal. So why do the structures and biomechanics don't match? And why do we come across cases where if preoperatively topography is absolutely healthy, normal with normal biomechanics, still the patients land up developing ectasia, and there are patients who have suspicious looking topographies or suspicious biomechanics, still they say stay normal after refractive surgery. So what is driving this ectasia? What do we need? Do we need to have a better diagnostic tool beyond our topography, biomechanics, or OCT to diagnose these cases? Our group has published in the past where we have published that patients with normal topography and biomechanics can have pre-existing low levels of collagen, which can land up into developing ectasia. Now, collagen fibrils are nothing but they provide the biomechanical prerequisite necessary to sustain the shape and provide the strength to the cornea. But at this point of time, the only way to measure this collagen is to excise the epithelium or stromal tissue, which can be challenging, and it is also invasive, which is not practical, or we cannot do it for refractive surgery patients. It is against our ethics. So the research question here is there a non-invasive way to study the collagen fibril orientation and distribution? And can we translate this knowledge into clinics for screening of refractive surgery patients and help us choose the right procedure for them? So for that, we need to choose the right principle. Polarization sensitive OCT, the polarization property has been into a research for in ophthalmology for a very long time, where they throw the polarized light on the cornea of the patient. All the structures of the cornea take up this polarized light except stroma, and stroma bifringes this property. So this does not take the bifringence property, and that's how we can study the fibril orientation and density of the collagen into the stroma. So we built our own optical system in collaboration of University of Vienna to study this collagen fibril orientation and property. How it is different from existing OCTs? It has a maximum, a higher maximum detector bandwidth, maximum image depth, full pixel is better, and pixel resolution is better in this OCT compared to those of others. It gives us information of epithelial thickness of 11 millimeters, which is not extrapolated. It is a true epithelium thickness of 11 millimeters zone. It gives us the information of Bowman's thickness. This is the first ever tool which can help us quantify the Bowman's layer thickness. Now, why is Bowman's layer important? If it's a thin Bowman's layer and if you do a refractive surgery in those patients, post-surgery they'll be difficult to maintain the integrity of the Bowman's membrane, and they can lead up to ectasia, and the thick Bowman's membrane will have a good quality. Now, this is a schematic. On the right side is a schematic representation of the collagen. This is how it looks like. On the colored image looks like are what is useful for our clinicians. Denser the blue or violet, that means denser the density and orientation of collagen is in that area, and lighter the blue or green it becomes, that means it's weaker in that area. Normal looks like you can see how dense it is in this area, and in FFKC and keratoconus you can see partial and complete loss of arrangement and orientation of collagen into that area. So this is how normal Pomfret keratoconus and keratoconus will look like, which we know from our topographies and biomechanics. But how can this PSOCT help us in suspicious KC? So we recruited 535 normals, 139 suspicious or thin cornea cases, and 337 clinical keratoconus cases. In beyond topography, biomechanics, and epithelial mapping, we did PSOCT for these patients. So we divided them into 4 groups. One with normal collagen distribution and normal Bowmans. The second with normal collagen and thin Bowmans. Third with abnormal collagen distribution and thick Bowmans. And fourth with abnormal collagen distribution and thin Bowmans. The first group received we can proceed and do any refractive surgery of surgeon's experience. The second group, where the collagen is good but the Bowman's layer is thin, you can do either a smile extra for or PRK for a low diopters, or if it's higher diopters you do a phakic IOL. If the collagen distribution is weaker to begin with, then you prefer doing a PRK extra for lower dioptric correction or a phakic IOL for a high dioptric correction. And if everything is on the weaker side, at the first sitting you choose a phakic IOL to do it. So let's see this case example. First patient has a suspicious looking topography, and but the biomechanics is normal, and the second patient has all parameters normal. If you do a polarization sensitive OCT, the suspicious looking topography has a normal Bowman's membrane and a normal looking collagen, whereas the normal topography has complete loss of orientation of collagen and a thin Bowman's layer. And if you do refractive surgery on them, the second case, which is healthy looking, will have an unfavorable outcome. So this suggests us that this is the first polarization sensitive OCT in the world in clinic to study the collagen orientation and arrangement in patients. It can help us differentiate healthy and suspicious looking corneas. Suspicious corneas revealed a unique distribution of collagen, indicating early changes before that topographic manifestation has started. So PSOCT can be an integral part of refractive surgery screening in the future to identify warning signs in seemingly healthy looking corneas which are posted for refractive surgery. At this point of time, and it can also give us the theoretical representation which you saw in the diagram, which has been published 25 years back by the primary author. So we have collaborated with a company to commercialize this tool, and this will soon be into your clinics. Thank you.
Nice.
Nice presentation. Is the available?
So that's what the last slide was. So we have already collaborated with one of the international company, and it will be commercialized soon once we have the regulatory approvals from our DCGI and their phase. And then it will be, we have Indian data from our clinic, but it has to be it has to undergo trial in various clinics as well. But a company has already taken over this technology.
So now that you have the PSOCT, would you say that it is a mandatory thing for every patient undergoing refractive surgery?
As I said, sir, topography has been there for ages before I think I was born or I've entered ophthalm. Biomechanics and OCT is there. So we do have tools. PSOCT is not for all the cases, but for suspicious looking corneas, definitely a tool. The future plan is that it will be a complete tool where you get a topography, OCT and the collagen from the same machine. So you will not have to buy 3 different machines, but a same machine will give all the information, but of course biomechanics will be different. So that's what the company's plan is.
Do you have comparisons between a tomography and PSOCT means?
Yes, sir. We have done studies to compare epithelial mapping from OCT and this. We have done studies where we can build a topography out of this tool and how it is look with our, how does it match with our traditional topography. So we do have the data, but the company doesn't allow us to present because they have now taken over.
Dr. POOJA, what do you think the role of Bowman's membrane with your study?
So Bowman's membrane, as I said, sir, we never looked at it, but it is very important because if it's a thin membrane, you can go ahead and do the surgery. But if those patients have any history of eye rubbing or they're going to rub their eyes in the future, especially computer users, they don't realize, but they'd always have a habit of doing this. So if it's a thin Bowman's membrane and they rub their eyes, even in a healthy cornea or a healthy topography, post-surgery, they are at higher risk of developing ectasia. So thin Bowman's membrane comes into picture there.